couple more images for you. Here's another one from our case series. So you can see a larger, more prominent and dilated esophagus as we get to the end of this clip, just to the right of the trachea. And again, this is really just about repeating that anatomy, being comfortable with watching an esophagus, have someone drink and swallow while you're ultrasounding them to understand that normal anatomy and look for those differences. When we talk about foreign bodies lower down, we had a patient who ingested one of these pins, and here you can see it located in the stomach. So remember, you can use ultrasound to look for some foreign bodies deeper down, but it's very difficult in the thoracic cavity itself to determine things. Once it gets to the stomach, if you have some fluid there, you can do similar techniques to assessment of pyloric stenosis to try and take a look at some of those foreign bodies. But again, with a radio-opaque foreign body, it may be more worthwhile to just do an X-ray. And that's all for today.
Very cool. I love the glass of water slides.
Thanks.
I've always had trouble kind of explaining that, flipping the patient has to be upright and the anatomy. So very cool.
Any questions, guys?
Are you going to speak about retroperitoneal?
No.
Question, and we've heard from people who join us online that often with the questions they have a hard time hearing
yes,
them,
sorry.
So.
The question was, are we going to speak about retropharyngeal abscess? And the answer was no.
And if you are approaching in a transcutaneous
view, yeah.
How can you measure how deep you will put your needle?
So that is the challenge. You have a few options if you're measuring in the transcutaneous way. So the question was, if you're measuring transcutaneously, how are you going to calculate how deep to sheath your needle? One of those is confidence in the anatomy itself. So if you're visualizing an abscess and you're confident you can see the anterior tonsil, and you're confident that that row of bubbles is going over the anterior tonsil, you can measure from the row of bubbles to the center of your tonsillar abscess. Also taking a measurement from there to the vessels. It's a little bit tricky, and I will be honest, in our institution, I generally practice in doing the transcutaneous because we don't have an intracavitary probe, and I don't tend to drain them. When I see them, I speak with the ENT, and sometimes they say, well, it's too small still, we're going to do IV antibiotics anyways, and we'll reassess later on. So really, I look at it from a transcutaneous approach as, can I save this child a CT, and can I get them quicker disposition in terms of an admission in IV antibiotics? I think that if you're going to sheath your needle based on measurements, you have to be very comfortable with the anatomy. So if you're in an area where you're seeing a lot of peritonsillar abscesses and you're really confident with that scanning and with your approach, I think you can do it very safely, but I think it is hard to do it transcutaneously and calculate your intraoral depth, because you're having to switch around that measurement a little bit, if that makes sense.
And do people know why we're not going to talk about parapharyngeal abscess?
You can see.
So you may encounter a few people that talk about scanning for it. I don't know of any primary literature to suggest the approach, the possibility. And you can think about why, right? Like how you're trying to access it, what are you shooting through, does air get in the way? Those are all very valid questions. And then it may be that there is an approach and it's just a matter of we haven't figured it out and published it yet. The next true parapharyngeal abscess you have would be worth a shot, seeing if you can convince yourself that you can find something that compares to the CT.
One of the things I would say about peritonsillar abscess is when I started working at this institution, and Mark showed me this scan, we did it in a patient, and got quite a lot of surprise from different subspecialists. So the radiology department was quite surprised that we were doing this. ENT was quite surprised that we were doing this. And now, after a few years, you're starting to see this body of literature being built up in radiology and in otolaryngology that supports and advocates for more ultrasounding in some patients where the risk of CT may be a bit higher. involving sedation or being a very young child. And so you're seeing a little bit of a shift, I think, in the literature from that initial kind of surprise this was even happening to more of an acceptance from the radiology and the otolaryngology departments, at least in our institution. I don't know if you would agree with that, Mark, but I remember that patient very vividly, and I think that there was a lot of confusion as to why we would bother to ultrasound, and standard of care is CT. And when we talked to them about how easy it was and how nicely we could visualize these abscesses, and really that's the question, right? If we think it's a disseminated abscess, it's complicated, and it's now involving vasculature, and you've got ascending infection, and you're concerned about additional extra tonsillar involvement, this is probably not the best investigation, right? Because it's very targeted. It's not looking at the entire midface. But for those kinds of patients that you just need to make that decision, you're going to admit, is it to pediatrics or is it to ENT? I think that's a really good conversation to have, and it's something that we're all trying to get better at as we do it, because our volume of peritonsillar abscess here just isn't that high compared to other scans that we do. So whenever we have those patients, we're trying to take the opportunity to learn from them. But it's one of those ones, because it's so uncommon, at least in our demographics, that it takes a little bit of time and practice to get your head around the anatomy of it, right?
One of those anatomical things that ties into a question that Ashcon from Islands has asked over text, which is, do you still see the row of bubbles on the transcutaneous approach as well? So my response to that is yes, and this is one of those few exams where we often have a patient who's sitting up. Most of the time our patients are supine or semi-supine, and often for this they're sitting up, and then you're putting a probe under the angle of their jaw, shooting upwards. So it's kind of like this double strange approach for what's on the screen compared to what you're doing, and you have to do that mental mapping in your head of completely flipping the image around. So you'll look at this round structure and you'll say, oh, okay, that's a tonsil. And then you have to do that extra processing of the stuff at the top of the screen, it's the bottom of the patient's jaw. The bubbles are going to be deep in the screen, they're going to be in the lower part of the screen, but that's the top of the tonsil. So there's just that full 180 you have to do.
And I would say, for sinuses, it's also hard to get a handle on the anatomy sometimes. And the challenge is there's really not a lot that's drawn out or described in this way, right? When we think about cross-sectional assessments in clinical examination books, it's all with your mouth open and your tongue out and your palate up. So thinking about the mouth as a closed unit and all of those mobile structures being closer together is also very challenging until you start to practice that anatomy with yourself, right? A lot of when we talk about ultrasound, and especially more novel applications of it, you have to get your head around the anatomy before you scan, so you can confidently say that you understand where things are, or you start to get a little bit confused. And it's worth sort of going through and practicing that, and maybe going back to your netters and seeing if there's some cross sections that make sense, because you do have to flip and then flip, so it makes it a bit more challenging that way. It's a great question.